Let me introduce you to my 6 months progress report of my PhD thesis, The Risk Factor of Atherosclerosis in Obese Patients. My name is Judit Eleonóra Nagy. I'm a first-year PhD student here. Also, I'm working in the pharmaceutical industry in pricing, and I just realized after Annette's presentation that I am that 1.1% of the group who's a pharmacist, so namely the only one. So my main focus is obesity because I genuinely believe that with a better management of obesity and the related comorbidities, we can improve not only the patient's quality of life, but we can also prevent or delay at least the obesity-related comorbidities, and thus we can reduce the healthcare cost. I have 3 ongoing projects. The first one will be a systematic review and meta-analysis. I would like to investigate the lipid profile of the different obesity phenotypes. The second one will be very similar. However, that time I would like to look into the inflammation panel, so to see a little bit more similar to MACEs, to see the different inflammation factors. Do they have any effect on the obesity phenotypes? And the third one will be a registry project. Until that moment, we are talking about the poor health outcomes, but in this one, it's more about the economic impact of obesity-related disease management and also the comorbidities. So my first project. I think it's fair to say that obesity is a global pandemic of unprecedented proportions with far-reaching consequences not only for the individuals but also for the healthcare and for the economies worldwide. Obesity is very closely linked to atherosclerosis, as obesity being the major risk factor of the development and for the progression of the atherosclerotic plaque, which is actually the #1 killer of the reason and the cause for the cardiovascular mortality and the death. Obesity contributes to atherosclerosis through several different pathways. The first one is a chronic low-grade inflammation. I will address it later on in my second project. And the other one is the metabolic dysfunction, for example, the abnormal lipid profile, endothelial dysfunction, or even the increased systolic blood pressure. Obesity is a remarkable heterogeneous condition with varying metabolic and cardiovascular manifestation among the individuals. And the obesity phenotypes is a kind of characterization which help the clinicians to have a better risk assessment of these different phenotypes. There is a really interesting phenotype. It's called the metabolically healthy obese patients. Clinically interesting phenotype, because these patients, apart from having overweight or obesity, they don't have any other health issues. Their blood pressure is normal, they have normal lipid profile, they have low inflammation grade, and they have intact insulin resistance. However, you as a clinician, you know from previous clinical trials that this status is a transient state. They will develop and they will progress into other formats. The question is how and when do they progress? When do you have to intervene with either life management or some kind of treatment? So my question in this case is there a lipid biomarker, and if so, which lipid biomarker have the highest predictive value for the atherosclerosis prevention and prediction in these phenotypes? I will use the PFO framework, where I will compare the different phenotypes, metabolically healthy and metabolically unhealthy, obese, overweight, and normal weight patients. And I will see the factor as the different lipid parameters. The outcome will be the CAC, or as we call in Hungary, the COTS score, which is measured by computer tomography. It is actually a very potent risk stratification tool, and therefore it is a really good marker of the subclinical atherosclerosis. So There is actually published already a meta-analysis as such, but it was published 5 years ago and based on only 6 articles, mainly on Korean patient base. So I think my meta-analysis will add to this subject because there will be some Hispanic, non-Hispanic, and also Caucasian and Afro-American patient population within my summary. You can see the final search which I conducted on the 5th of December. Altogether, I had quite a lot of hits, almost 30,000 articles. After the duplication layer removal, the abstract selection, and the full text selection, we have came down to 13 articles, which seems to be a manageable number. However, I realized during the progress of this data extraction that because I need to extract all the lipid data as on top of all the metabolic parameters for the different phenotypes as well, so it took actually longer time than I expected, but we have finished that, and the next phase will be the statistician interview and have the final figures and tables on it. So this was my first project. Let's move to the second one. The second one is mentioned in the beginning. The obesity attributes to a low-grade chronic inflammation. The key features are here, the elevated level of inflammatory factors. There are also a shift from the non-inflammatory M2 macrophage to a pro-inflammatory M1 macrophage, and also there is an elevated level of inflammation marker like the high-sensitive C-reactive protein in the circulation. So this kind of low-grade inflammation contributes to insulin resistance, type 2 diabetes, and other kind of metabolic abnormalities. So in this meta-analysis, my main question will be that is there an inflammation marker, and if so, which one has the highest predictive value for atherosclerosis in the obesity phenotype? Again, I will use the similar framework. However, this time I will a little bit broaden up the outcome. So not only look into the CAC, but I will also look into some other imaging and other presence of progression of the atherosclerosis. We have already conducted the preliminary search. Again, I will have quite a lot of articles based on the trendiness of obesity and metabolic disorders. So I expect to have a lot of hits. Let's see how we end up. And last but not least, I would like to talk about a very interesting registry project. Until this moment, we have discussed about the poor outcome of the obesity. Now, I would like to examine a little bit more about the financial part of the obesity-related treatments and the comorbidities. There are some data from the US saying is that the obesity-related work absenteeism, meaning that the workers are missing days because of their obesity or the obesity-related comorbidities, end up into a really serious amount of money. It's more than $8 billion US. There are some European data set. However, we don't have really a comparison between the European countries. And it would be very necessary because, unfortunately, Hungary is by far leading the obese statistics in Europe. It's really striking that almost 1/3 of the adult population has either overweight or obesity, and almost every 4th adolescent child and teenagers, they are either have obesity or overweight. So it's really huge, and actually it's just to show you the impact on the economies. There was a previous PhD thesis on the economic effect of obesity, and it's really striking that by the end of this century, they expect that in Hungary, the total GDP spendings will go almost 0.8% to the obesity, which is a huge number. So in this case, we will use the PICO framework. We will examine that is there any difference between the work absenteeism in obese and overweight population among the European countries, because our hypothesis is that workers with obesity obviously will have much higher compared to the normal weight. So this is my, my final slides. You see the progress of my 3 projects. And being, I think, among the oldest in the group, I think I can say that intellectual growth should commence at birth and only cease at death. Thank you.
Thank you for your presentation. It was really interesting. I would like to ask, the populations, are they pediatric populations?
No.
Or?
No, we have excluded all the pediatrics population. It's only for adults, at least this meta-analysis. However, there are some really interesting articles on adolescents as well and children.
Yeah, because I think it's like where it should start.
Absolutely.
That's what I was
I think
curious.
obesity treatment will start with prevention. So
yes.
the treatment is already late and very costly.
Yeah, that's what I was curious about. Thank you.
Thank you.
So, very nice presentation. Thank you for that. I'm curious that for metabolic syndrome, there are many definitions. Which one will you use in your...
Yeah, it's a tricky question because I just looked it up. There are more than 50 different definitions. Most of the articles, they're using the adult treatment panel definition. So it's good because we can pull those data together. But there are some articles which have other characteristics. So they consider and they define the metabolically healthy people as having normal blood pressure, normal lipid profile, intact insulin sensitivity, so the fasting sugar should be good, and some of them even add the inflammatory factors. And they consider if none of these criteria are there, it's one definition. The other definition, which is widely used, where they have less than 2, meaning only 1 is allowed. But we can only we can only pool those data which are comparable.
Very nice presentation. I would have one question. So statins are very much prescribed. I think in the US alone, yes. It's like in the top 3 prescribed medications. Did the original articles address the fact if the individuals in your sample were taking statins?
Yes, and that's one of the reasons why actually the data extraction took that much time, because in the beginning I was not extracting those data that are they having dyslipidemia, because that was one basic data, and another one is that are they on treatment currently. But now I'm involving those data as well, so there will be some statistic. However, from my other life, I know that you would be surprised at how bad is the compliance of the statin therapies. So it's less than 9 months. So they are on and off on statin therapy. So obviously it helps, but you cannot really say that if you're prescribing a dyslipidemia treatment, they will be on that treatment forever, because that's not the truth.
Okay, and then a second question. So are there any other drugs which might have a confounding effect on your...
All of these which somehow involves and somehow treats the metabolic syndrome, so blood pressure, anti-hypertension product, any kind of antibiotic, or anti-diabetics, and all the lipid, anti-lipid therapies are included and also concomitant.
Okay, thank you.
One more question. Do you have any information about comorbidities in your 3rd project? So, yeah. For example, can you differentiate there also metabolically healthy and unhealthy
Not
patients?
in that questionnaire, but they use also concomitant comorbidities. So I think that what would be good to decide in the beginning and to have an exclusion criteria is that which disease codes should be considered as a concomitant, as a kind of comorbidities to obesity. And we have to decide right from the beginning. Yeah.
Thank you.
Yeah. Sorry, so you mentioned these clinically interesting cases who are obese but clinically healthy. Can we find these patients in the older population as well, or only with young people?
No, I think definitely, but I think those practicing clinicians, they know better than me, is that they are existing, and they have, we just talked with MSA, is that she has patients who are completely normal parameters on every clinical baseline, but they are obese. So you kind of wait what to do with them, and of course you try to convince them to lose weight, but the question is still there.
Thank you.